Well, hello and welcome to HealthLine. I'm Jennifer Blomquist. I have the privilege of hosting the program this evening, and I'm so glad you joined us. If you're one of our regulars, you know how it goes. We are live here in the studio, and this is a great opportunity to ask our guest questions live during the show. We have a surgical podiatrist with us tonight. So if you have feet issues or if you have ankle issues, he's your guy, and you can ask him questions. That's why we leave that phone number up at the bottom of the screen throughout the show. So it's 969-2720. If you're outside of Fort Wayne, it's still a free call. Just put that 866 in front of there. And I want to remind you that you have two options when you call in. We don't just throw you on the air, especially if you're a little nervous, that you'll talk to a call screener. A very nice lady will talk to you, and you can either ask your question live, which I think is a great option because then the doctor can maybe interact with you, or maybe he needs to ask you more questions to better answer you. So that's one option. But another option that works perfectly well is just tell the call screener what you would like me to ask the doctor, and we'll get your question answered that way. So either way is great, but again, call sooner rather than later. We only have them here for about half an hour. So again, we'll keep that phone number up at the bottom of the screen throughout the show. Let's go ahead and introduce you to our guest tonight. It's the first time he's joined us. This is Dr. Stephen Douthett. And again, you are a surgical podiatrist.
Correct, yeah. Thanks for having me.
Thank you so much for coming on tonight. And he's got two little ones at home, so you know how crazy that is. So we definitely appreciate your time tonight. And we thank your wife for loaning you to us.
Of course.
So you're dealing primarily as a podiatrist with just the foot, and also you deal with ankle issues.
Yeah, foot and ankle. So everything basically below the knee is something that I would treat.
Do you find, I know we wanted to talk a lot about bunions tonight, and so, but a doctor has said, if you have something else other than bunions, that's obviously a specific topic. If you have something else ankle or foot related, please call in, because that is his specialty, and so he could at least give you some advice or point you in the right direction if you're having some issues. But we're going to go ahead and start our topic tonight talking about bunions. Yeah. I imagine most people have probably heard of bunions or know somebody who said, oh yeah, I'd have some bunions removed. Yeah. But can you just kind of describe what exactly they are?
Yeah. So there's a lot of confusion about what a bunion actually is. What it is thought to be by most patients is a bony growth or like a tumor essentially. But what it really is it's a malalignment of the first metatarsal, so the long bone in front of the great toe starts to deviate and creates that large eminence, and then the big toe then deviates towards the lesser toe and creates the bunion. There are different types of bunions as well. There's an arthritic bunion where the patient actually has bone spurs and they consider that the bunion. And then there are also patients that have gout and they develop a buildup of gouty tophus material, which is like a deposit that creates an eminence that's similar to a bunion as well.
Are they always painful or?
Not always,
no,
actually.
Okay.
You would find that a lot of patients that have bunions don't even know they have bunions because they don't cause any pain. It's typically painful if the patient is developing arthritic changes and the joint is starting to grind, or if the patient is wearing shoe wear that's a little bit tighter and it's starting to cause some friction in there.
You had mentioned bone spur, because my mom had one of those and it was painful. So is that a totally different thing?
No, there are bone spurs all over throughout the body, but in this instance the bone spur is typically on the top of the great toe joint, and it rubs against the shoes and causes a grinding sensation in that big toe joint, and that's what causes a significant amount of pain for some patients.
What does it, I've seen some pictures of it, but I've never seen one in person. Yeah. So can you kind of describe what it would look like?
The bone spur?
Yeah.
Yeah, so if you were to look at the foot, essentially there's going to be a big lump over the great toe joint, and if you were to touch it, you would feel almost like a spike underneath the skin, and that's what it would look like clinically. When we actually get into surgery, what it is, it's a buildup of bone that has kind of accumulated on the top of, in this instance, the first metatarsal or the toe bone, the phalanx, and it's just basically right over the top of where the joint is.
And that was the next thing I was going to ask you about, is treatment options. Most people want to do whatever is less invasive.
Yes.
And I know in your specialty, in orthopedics, all of your colleagues who've been on in the past say you always start conservatively.
Yep. So for bunion management, the vast majority of patients don't require surgery. We can usually control their symptoms with accommodative shoes, so shoes that are wider or shoes that are more roomy and allow for that bunion to kind of breathe, if you will. Other things that may help would be anti-inflammatories. So if the bunion is acutely inflamed after certain activity and the patient takes anti-inflammatories, that can calm it down. Other things that you'll see that may help with symptoms would be night splint, like a bunion splint that you would wear at night and try to stretch the toe into a straighter position, or padding that you can wear in the shoes, or even a toe spacer that kind of aligns the joint in a little bit better position. These things don't fix the bunion, but they can kind of give you relief to the point where you may not require surgery because it makes the joint feel better when you're wearing them.
Yeah, I think people like the idea of trying something simple instead of jumping in and doing surgery.
Of course.
I just want to remind everybody we are talking about bunions right now, but Dr. Douthett is a podiatrist, a surgical podiatrist, so he knows all sorts of things about ankles and feet and issues you may have. So feel free to interrupt us at any time. We'd love to hear from you. Again, the number is 969-2720. If you're outside of Fort Wayne, make it a toll-free number by putting an 866 in front of there. So if you try these conservative methods and you're not really finding success or relief with those, is surgery the next step then?
Yeah. It doesn't usually respond well to injections. It may give you temporary relief, but usually the curative treatment is going to be surgical intervention, and that comes in various forms. So it depends on the severity of a bunion, if it's a small bunion, a medium bunion, or a large bunion. It depends on the surgeon performing the procedure and their comfort level and the patient's expectations. So there's everything from a large incision bunion procedure to minimally invasive bunion procedures, which are basically done through poke holes, and that usually results in less swelling, less pain, faster recovery, and less stiffness. So the patients are typically very pleased with that procedure. There are patients that unfortunately can't have that procedure because they may have arthritic changes or a gouty deposit that requires a different procedure, though.
So if, when you were talking about sometimes they can be kind of big, so in a situation like that, you actually have to make an incision, and then how do you remove it, or do you shave it down? Or?
Yeah, so if the bunion is large, there are still times that we can do a minimally invasive procedure. It just depends on different factors in the radiographs and the clinical exam. But the procedure itself typically entails either fusing two bones together to realign them, or cutting the bunion itself, shifting the bone into a corrected position, and then using screws through small incisions to hold it together while it heals. After the bone mends, it's in a straighter position and the bunion is gone.
And then you just leave the screws in it, like as if, I mean, I think people are thinking of, arms and legs that get broken and have the screws in it. I didn't know they would do that with the toe.
Yeah, with bunions, we have anatomy-specific instrumentation and hardware that can basically stay in there forever, and the patient doesn't know it's even in there most of the time.
Can you, when you're doing a surgery, first of all, I don't know if it's common if people would have more than one bunion at a time, and can you do surgery on multiple bunions at one time?
Yeah, so if a patient has two bunions, meaning both feet, typically we don't do them at the same time for safety issues afterwards.
Sure.
They're in a protected weight-bearing device typically after surgery. But a patient can have a bunion on the great toe side and then a bunionette or a tailor's bunion on the outside by the pinky toe, and those could be addressed at the same time through similar procedures, and the patient could potentially weight bear after surgery in a protective device.
I was going to ask you about the recovery. So, first of all, is this something do you have to be hospitalized to do it, or can you do it as an outpatient
No,
thing?
It's an outpatient procedure. Okay. The patient is typically under light sedation anesthesia, and they get some form of regional block.
Yeah.
And then afterwards, the patient is either put into a weight-bearing boot, or they're on crutches for a very short amount of time, and that boot protects it while it's mending for the first month or maybe 6 weeks, and then from there they can transition into normal shoes and gradually get back to their activity.
So it's not terrible.
It's not typically crutches for months and months like the horror stories of the 80s and 90s that a lot of patients have heard. Yeah.
Oh yeah, things have changed so much, and
definitely.
Even just the outpatient care. I mean, things where you think you'd be put under anesthetic, and you're pretty much just awake.
It's day surgery, and 30 minutes later, you're in the recovery room. So pretty quick.
All right. Well, that's good news. Most people like to have it done and over with quickly. So
yeah, for sure.
We did get a call from someone named Sally, and she wanted me to ask the question for her. So, doctor, she wants to know, what is the best thing to do for nail fungus in the foot?
Yeah. So nail fungus is a tricky thing to treat. There are topical and oral antifungals for toenails. Typically, the topicals are not as effective as the oral antifungals, and that's usually because the patient abandons treatment because it requires 8 to 10 months of treatment, and people get sick of painting something on their toenail every day for 8 to 10 months. And then there are oral pills. The oral pills are taken once a day for about 90 days. The only problem with the oral pills is they're metabolized in the liver, and if a patient's on cholesterol medication or if they have any type of liver issue, we don't like to prescribe it because it can kind of cause the enzymes to raise up a little bit. But the pill is the most effective treatment, unfortunately, in that instance for the side effects.
Yeah, I didn't know. We've had, some of our kids have dealt with warts, which are so stubborn. So I didn't know, and I've heard the same of nail fungus too, that it can be kind of stubborn. I mean, once you get rid of it, can it come back pretty easily?
Yeah, it does have a high recurrence rate.
Okay.
There's a reason that the toenail fungus set in the first place, and it's usually, either the patient's nails have a little bit of kind of loosening, so the moisture can accumulate underneath there, or they're someone that has more sweaty feet, and unfortunately that isn't cured with the nail fungus, so it can recur.
I just know it looks ugly. You know? I mean, it's most people, and in the summertime when you want to maybe wear sandals or flip-flops, it's a little.
It's a cosmetic issue. Most of the time, it doesn't typically cause pain, or it can't go systemic. So it's more of a cosmetic issue.
All right. Well, Sally, thank you so much for that call. And we actually have somebody else calling in right now, and she's going to ask her question live, I believe. Anne, are you still on the line?
I sure am.
Oh, thank you for waiting. You have a question for Dr. Douthett.
Yes. I had knee surgery 2 years ago this January, where I had a complete knee from the arthritis and bone on bone. This summer, the top of my left foot, where I had the surgery on my left leg, I could tell that there was a little swelling, and there was pain on the top of this left foot, which now has increased and has gotten worse over the months, where it sometimes is really painful to even stand or walk. And I'm wondering if it's related to my knee surgery or if it's something completely different. But it's almost getting to be a quality of life issue for me, because it's just too hard to stand on my feet and walk a lot.
Oh, yeah.
Yeah. So it sounds like in this instance you may have had pretty severe knee pain ahead of the knee replacement surgery, and then after the knee was repaired, it may have unmasked the foot problem. I don't know that it's necessarily related to the knee surgery, but I would suspect that if you were to have an X-ray, it sounds like you might have what we call midfoot arthritis, or arthritis in some of the joints in the middle of the foot. So that would be something I would definitely check into. A lot of times arthritis of the midfoot is treated with anti-inflammatories, nice stiff shoes to prevent flexion of the bones of the foot and too much motion through those arthritic joints as a first-line treatment. And there are procedures that can be done, injections, things like that for midfoot arthritis as well, if that happens to be what's going on.
Anne, I don't know if you're still on the line, but did you want to ask Doctor anything else?
Well, I just wondered about my varicose veins. Would it have anything to do, because I do have really bad varicose veins, do you think it would have anything to do with that either?
Sometimes patients that have varicose veins, they do end up capturing a lot of edema in the foot because of gravity. It likes to pool and accumulate in the foot. And that edema or swelling can lead to increased pressures in the soft tissues of the foot, and that could lead to foot pain as well. So that could be something that's leading to it. For edema or varicose veins, I'm sure you're aware, but a lot of times the mainstay treatment would be compression stockings or even diuretic or water pills to help get rid of some of that fluid, and that may alleviate some of the pressure in the soft tissue envelope of the foot and relieve some pain as well.
So it sounds like she should start by trying to go see somebody and seeing about an x-ray. That would be the first step.
Yeah. First step is have it evaluated and see which direction, to go with it. Yeah.
All right. No, Anne, thank you so much, and I hope it all works out. It sounds like if it's some of the issues you've mentioned, that there are some things that can be done to alleviate her pain, because it sounds like she's in a terrible pain. So.
Yeah.
I wish her well for sure. We had another woman call in. She wanted me to ask the question for her. It was Catherine. So she wants to know, what would you suggest for periodic neuropathy in the foot or in the feet accompanied by pain? Yeah,
so that's a good question. The first thing with neuropathy is really understanding what the cause of neuropathy is. So neuropathy is a blanket diagnosis of nerve conditions, nerve pain. A lot of times neuropathy in the feet, it could be related to diabetes, it could be related to alcohol use, it could be genetic, it could be a lumbar or a spinal impingement leading to nerve impingement that's leading to the foot and caused that foot pain. So step number one is understanding where it's coming from, and then step number two would be treating either that causative factor or making a patient more comfortable with medications like Neurontin, which is gabapentin, Lyrica, and a lot of times a pain specialist gets involved and can kind of down-regulate the nerve pain. There are also topical medications that can be used for neuropathic pain that almost desensitizes the nerves a little bit. It's got capsaicin, so like red hot pepper, in it, and that can be spread on the foot and almost cause a burning, tingling sensation, and then you wipe it off. And the thought is that may desensitize the skin and kind of downregulate some of that hyper feedback that the patient is getting from the neuropathic symptoms.
Would neuropathy, would a patient like that get any benefit from a certain kind of footwear or like a prescription even type of shoe?
Yeah, a lot of patients that have neuropathy, they happen to be diabetic, and in those instances, it's actually wise that the patient get into a certain type of shoe with an insert that's custom molded to alleviate pressure points. The problem with neuropathy is if a patient is walking and they're rubbing against something and they don't have that proper nerve feedback, they could develop a sore, an abrasion, and develop an infection without even knowing it. So there are shoes and inserts specifically designed for those patients, yeah.
I guess I want to also point out, we've had some other of your colleagues in podiatry on the show, and I know a lot of them have said, hey, at some point, don't do these over-the-counter things, where you walk on a scanner and it's like, oh, this is the kind of insert you need for your shoe. A lot of them have said that if you're having some serious pain, it's really best to talk to somebody who really knows what they're doing. Yeah,
definitely. You get what you pay for sometimes. So, if you step on a monitor and it tells you what insert's going to cure your back pain, it might be too good to be true.
Yeah. For $5.99, that's probably not going to be the best outcome. Well, you're very popular tonight, so we have another person who called in, a gentleman named Wesley, but he wanted me to ask his question for him. So he is asking, are there any treatments that are not medications or ointments that can help with the toenail fungus? Yeah,
so there's a lot of anecdotal discussion about different treatments for toenail fungus. So things that I hear, but I don't recommend because there's not enough literature to really prove it. But a lot of patients will use like tea tree oil, or they'll use Vicks Vapo Rub, and what that does is it almost softens the nail, which then allows the person to kind of almost dig out some of the nasty debris. So that may help with it. It's just not something that has been studied in a controlled environment.
Yeah.
So for the topicals that are actual medications, those are probably going to be a little bit more effective as far as less invasive treatments than like the pill.
Sure. Do most people, if you get that toenail fungus, I mean, I just look at them, they look so dry and, and just crumbly almost. I mean, does anyone ever like lose the whole nail from a fungus, or would that happen?
Usually the nail gets quite thick, and then the patient's getting some rubbing on the shoes. Then they come in, and a lot of times we'll do a nail avulsion or remove that toenail for the patient, and there's ways that we can make it so the toenail never grows back again, so they don't have to deal with any toenail whatsoever. And those patients are the ones that you're describing with the crumbling, thick, kind of nasty toenail.
Yeah. No, we were talking before the show. One of my boys had to have a strip of toe of the nail removed from each of his big toes, or the great toe, as you say. I was horrified, thought it would be terrible, but actually, I mean, it gave him so much relief because he was always getting infections from, there was so much nail and the skin would grow over it like an ingrown toenail. So it really wasn't that bad, and now he's pain-free. So that's it's a lot simpler of a procedure than people think. To have a nail avulsion or a matrixectomy where we kill it off, if you will, so it doesn't grow back. No, it was quick, that's for sure. So let's see, another person called in, wanted to ask a question. We may get back to the bunions at some point, but if not, we appreciate the calls. The questions are great. Selena's asking, what does the minimal invasive surgical technique for bunion removal look like?
Yeah, so basically what it is it's a procedure. The patient goes in to the operating room under sedation anesthesia. They get some local anesthetic to numb up the area where we're working. We make a poke hole right at the neck of the metatarsal, so right where that protuberance is on the metatarsal, and we actually use a specialized burr that cuts the bone. We then shift the bone over to get it into straighter alignment, and then we drive these small titanium screws into the bone to hold it in place. We bandage them up. A lot of times I actually do it with no stitches, so the patients don't even have stitches in certain instances. And then we put them in a small surgical boot or a surgical shoe and let them weight bear to tolerance afterwards. A lot of times you'll want to put weight on your heel afterwards and keep it off from the ball of your foot. But you wear that surgical shoe or surgical boot for somewhere between 4 and 6 weeks, and then you're back into comfortable sneakers and then running, jumping, kicking somewhere between 8 to 12 weeks. You're back at it if everything heals accordingly.
Yeah, that was, her second part of Selena's question was the post-op. So I was just wondering, does anyone that has bunion removal, would they ever need to do any like physical therapy, or do you give them certain exercises to do? Or?
So that's a great question. The traditional bunionectomy, where we're doing a larger incision, the patients form adhesions a lot more, so they get a lot more stiffness. So that is something that requires physical therapy, lots of range of motion exercises and joint mobilization type techniques. The minimally invasive technique doesn't violate the joint capsule itself whatsoever, so you don't form those adhesions. So the patient's range of motion is great right after surgery, and they can bend the toe just fine. And physical therapy is not necessary unless 8 to 12 weeks later the patient is not getting their gait back accordingly, and they just need a little help with gait training. But most of the time they don't require physical therapy.
Yeah, that sounds great. I think a lot of people get bummed because some of the orthopedic surgeries require months of physical therapy, and that can be a bummer for sure. So I think somebody's going to ask a question live. Connie, are you still there?
Yes, I am.
Oh, thank you for waiting. Go ahead with your question.
Okay, I had a spur taken off my heel about 10 years ago, and every 9 months it forms a scar, and I have to pull it and peel it off. Does the heel heal from the inside out?
So in your case, it may actually be a callus that keeps reforming at your surgical scar. When you're describing peeling something out, it sounds like you might be developing a thickened callus over your incision site, and that callus builds up to a point where it then is ready to slough off when you remove it, and then it forms again after more friction occurs in your shoes, is what I'm speculating.
Is that something, should she maybe have a return
I
visit
would-
with the physician that she dealt with
Yeah,
before?
I would definitely follow up with the surgeon or a surgeon to take a look and just make sure that there's nothing else going on that might be leading to, some buildup of skin or potentially, it could even be a small wound that continues to drain from time to time that may need to be addressed.
All right, sounds good. Connie, thank you so much for your question, and many thanks to everybody who called in tonight. Great questions, I appreciate it, and certainly appreciate your time. Again, this is Dr. Stephen Douthett, a surgical podiatrist. So nice to have you on. So
Yeah. Thank you for having me. It was great.
See, he was all nervous. It was his first time doing it, and I said it'd be a piece of cake. So it was great. He did a great job. Hey, and this is my last program until the end of the year. So I just want to wish everybody a Merry Christmas and a very Happy New Year. Hope you get to spend a lot of time with family and friends, and stay healthy. So take care. We'll see you in the new year. But there is another HealthLine coming up next week. Take care. Bye-bye.
The preceding program on PBS Fort Wayne was made possible in part by...
It's a new day at Parkview, another day to rise up and make life better for those around us. Whether that means pushing the boundaries of what's been possible, taking big strides, or sitting with a patient long after a shift has ended. At Parkview, we don't just do what's expected. We do what's best for you and your family. And we're determined to do it even better tomorrow. Every person, every day. That's the kind of healthcare we believe in. Parkview Health. We believe in better.